Good evening, doctors. This is second. Uh, Sorry, is there? Please don't ask questions because we are just starting the session, and if there are any questions, we will take them at the end of the session. So don't raise hand or ask queries. So welcome, doctors. This is the second national learning session, second this week. We had a backlog of one case which was to be discussed. It was a case number 85, the elderly patient with a weight loss and abnormal chest X-ray. We have with us, we welcome Dr. Ravi Chandra from National Tuberculosis Institute, Bangalore, and Dr. Meshur Srivas Kumar from Hyderabad, uh, who is, I think, must be on his way to join us. I welcome all for this nationwide learning session. Now, this was the chest X-ray of the elderly patient. And this is the abnormal area in the right upper lobe. This is the abnormality, predominant abnormality seen on the chest X-ray, and there's some infiltrate here. But you can see some cystic shadows, very faint. You have to magnify. If you are watching this session on mobile, you can magnify your slides. You can do that like normally you enlarge the photos or the videos. You can do that with your fingers. So you can see some cystic shadows in right upper lobe. And this patient most probably had some cystic shadows in the right upper lobe. So we wanted to confirm that. So we went ahead and did a high resolution CT scan of the thorax. And then this confirms our suspicion that there are multiple cystic shadows in the posterior segment of the right upper lobe. There was no other abnormality seen. So, and the patient had no previous history of any infection or tuberculosis in the past. So we investigated this patient further. Uh, but what investigations we should be doing in such presentation in a patient who has a weight loss? It was the only complaint this patient had. So complete blood count, ESR, chest X-ray has been done in this patient. Weight loss in an elderly patient can be a new onset diabetes. So look for hyperglycemia. It can be thyrotoxicosis, hyperthyroidism. So do thyroid function test. But most important concern in our elderly pensioner is malignancy. Here you should at least do these two basic investigations, ultrasound of the abdomen, and you have to ask abdominal symptoms. Sometimes the patient may not tell you voluntarily, but go on asking dysphagia, burning, any pain in abdomen, any melena, any PR bleeding, and you can accordingly think about any endoscopy as per the history. So this patient was investigated. He underwent a bronchoscopy. The bronchoalveolar lavage, which was displayed in the quiz question, was positive for acid-fast bacilli. It was 3 plus. And based on the report of the bronchoalveolar lavage, we started this patient on 4 drugs, anti-tubercular drugs, rifampicin, INH, pyrazinamide, and ethambutol. And this patient also, we sent the culture of the ball for AMD, which was about to come in 6 weeks. So till that time, we put this patient on 4 drugs, anti-tubercular treatment. So this was a case of tuberculosis in elderly patient as per the report, but the culture came negative. So there was a dilemma. This patient has a weight loss, which is a significant weight loss. And over a period of 1 month of anti-tubercular drugs, this patient actually started gaining weight. So I was in a dilemma what to do, whether we should stop the anti-tubercular treatment because the culture is negative, or I should neglect that he's had a weight gain, significant weight gain after starting AKT. So the clinical decision was taken that he should continue on AKT, and this patient was being followed up. Even he is being followed up in my wellness center. So Dr. Ravichandra is going to explain to us some of the dilemmas in this patient and going to take us through how tuberculosis in elderly patient presents in our practice. Dr. Ravichandra, sir, over to you.
Thank you, sir.
Yeah.
Sir, the important features of TB in elderly, they are more frequent lower zone and more frequent miliary shadowing will be seen. It will be difficult to differentiate and say if we are expecting the upper zone typical of tuberculosis. We may not get all the signs and symptoms typical of tuberculosis in an elderly patient. It is also same in case of pediatrics as well as diabetes and HIV patients. Nearly 3 times more likely to have reactions to anti-tuberculosis drugs. And more pathetic is the patients will not be able to tell you whether the patient is suffering or what are the symptoms. They will not be able to tell. And 6 times more likely to die from tuberculosis because they are not recognized early. There is always a delay in diagnosis of TB in case of elderly. So there should be a very high index of suspicion in elderly patients. Over 20 times more likely than young patients to have the diagnosis made at autopsy rather than during life. So this is going to be the case. Then the pathogenesis is mode of acquiring TB is 90% endogenous reactivation. That means the infection has happened. Many a times in India, you know that around 40 to 50% of our population is already infected. Not that everyone will suffer in their life. Only 10% of the 40% population of India will suffer from TB in their lifetime. Anytime in their life, they can break down to disease. Otherwise, they will remain a case of infection, but not having a disease. They don't need any treatment. So these patients, when they grow elder, that is more than 65, 70 years, there is a chance that they may break down to disease. So such is the case in case of 90% of cases. So it is known that age-related decline in cell-mediated immunity happens, which influence reactivation of latent infection into TB. So many a times, you know that humoral immunity will not come down. It is only the cellular immunity that comes down. So clinical features are also a little bit misleading. Primary infection leading to disease is least common, as may happen in nursing and old age homes. That means the person getting infected immediately breaking down to disease. It happens usually in children, but not in the elderly or adult population. Elderly, there is a chance. Pleurisy and diffusion. So pleurisy and diffusion, there is a chance. Frequently in older individuals, the onset is very insidious. So post-primary, more likely to present with complaints of dyspnea and right lower lobe infiltrates. These are the possibilities. So clinical presentation, the other points are elderly TB patients may have atherosclerosis, previous gastrectomy, malignancy, whereas alcoholism is more prevalent in case of younger patients. So because of the associated so many other diagnoses, we may tend to neglect TB. The classic symptoms and signs of tuberculosis were noted in a significantly higher proportion of younger group and not in case of elderly. So following is the breakup. Like fever is seen in 62% of younger patients when compared to 37%. One-third will not have, one-third will have fever, but the others may not have. Weight loss, 76% in case of younger, whereas 34% in case of older. Night sweats, a very interesting topic because not all patients will present with night sweat, though when it is there, we have to consider it. 48% in younger, whereas 6% only in case of elderly patients. So this sweating is more commonly seen in the HIV group where they present with the extrapulmonary TB. Sputum production, 76% in younger versus 48%. And hemoptysis is less likely to be seen in elderly patients. So abnormal mentation was more common in the elderly group. So this is the reason they may not be able to tell you what they are suffering from. So we may have to elicit and we have to have high index of suspicion. Mortality related to tuberculosis was 20% in elderly men versus 3% in case of younger ones. Thank you, sir. Then the lower body weight and less hemoptysis, but more non-specific complaints is the case with elderly patients. So less likely to have upper lobe infiltration. Classical upper lobe infiltration may not be seen in many a times. So we should be very careful. That's why the advice now is to see X-ray, any abnormality, suspect TB. First thing to rule out is TB when there is an abnormality. You don't need to have a upper zone. You can't wait for an upper zone infiltrate to suggest to you that it is TB. So there are so many cases where there is other, like for example, lower lobe disease, which has the upper segment, they may present as though it is the middle lobe lesion, and we may not be able to suspect TB. And the most commonly, the abnormality that is seen in biochemistry is albumin level, though the other abnormalities are also seen. Next, sir. Occurrence of anemia, hypoalbuminemia, hyponatremia, hypokalemia, and deranged liver function test. These are all possibilities that can be seen in an elderly patient. We should concentrate on this hyponatremia because many times these elderly patients you may not be able to find a lesion, extrapulmonary lesion anywhere. You searched everywhere. Patient is complaining of weight loss and hyponatremia is there on testing. There is a possibility that the adrenals may be affected. Of course, for that you may have to prove it by doing a lower cortisol levels early morning. So all those things we have to see. So this is a possibility one should keep in mind. Thank you. Next. So diagnostic challenges are also there. We have diagnostic challenge because the patients will not be able to give the sputum. Inability to give an accurate account of their symptoms. Wrong attribution of symptoms to the effect of old age. Even the relatives will start saying that because the patient is old age, he is complaining of so many complaints. So atypical radiological findings like solitary nodule, mass-like densities, extensive bronchopneumonia, and lower lobe infiltrates. These are all the possibilities. Though they are not typical of TB, one should keep in mind TB as a possibility. Malignancy to be kept in mind because in the zeal to investigate for TB, we should not forget malignancy in old age. Also associated other lung diseases may lead to confusion because, like for example, COPD is there. There are some other cough may be because of COPD. We may misjudge. High index of suspicion is needed as there is less symptoms, and non-specific symptoms are more common in elderly. So smear positivity is very less. So they may not complain of cough also. Many patients are stoic. They feel that this cough is there, so no need to worry. So that type of mentality will be there. They may not complain. Occasionally, we may have to go for fiber optic bronchoscopy to diagnose. Next. Adverse drug reactions are also more common. Nearly 3 times more likely to have reactions to anti-tuberculosis drugs as compared to younger patients. So advancing age is an important predictor for hepatotoxicity due to INH and rifampicin. So they add up. Rifampicin combined with INH has an additive hepatotoxic effect. So it is not synergistic. So they add up and cause more damage. So monthly monitoring of serum transaminases is advisable in such patients because you cannot rely on bilirubin levels. Bilirubin can be high because of rifampicin, and that is not because of the toxicity many a times. This monthly monitoring, first 2 to 3 weeks is the adjustment that happens because of the INH and rifampicin. When we are giving hepatotoxic drugs, transaminases may rise. Also, one should keep in mind the alcoholics, where you know that ALT may not rise. AST will be only one which is rising. So if ALT is not rising, then it may be probably because of the alcoholism. So these things one should keep in mind. Ethambutol can cause diminution of visual acuity. Already the patient is having some visual problem. It is very difficult to suspect or diagnose visual problem because of ethambutol. So we should keep in mind that ethambutol can cause Snellen and Ishihara chart should be kept in when the patient is started on, especially so in case of pediatric. Side effects of injectables. Nephrotoxicity and ototoxicity due to streptomycin is more frequent in patients with pre-existing renal impairment and is generally irreversible. So one should be careful. The moment we see, we should stop these injectables so that they will not suffer more. Half of those who recover or get cured because of the MDR therapy, they will suffer from hearing difficulties. So we have to test audiometry very frequently to see early indication of hearing loss so that we can stop these injectables. Next. So interactions are also more common. If the patient is already on anticonvulsants, INH can play havoc. Rifampicin can interfere with the actions of ART. So we have actually the TEL regimen has come where the rifampicin will not have much effect. Then OCDs also it interferes, the digoxin also, talbutamide, corticosteroids. So all these problems are there because of the ATT. So the other dilemma, gene expert is positive and culture is negative. If the patient is on treatment, the bacilli may be dead and hence there will be no growth. Gene expert can detect the DNAs that are there. DNAs that are left behind by the dead bacilli will be picked up by the gene expert, which is very sensitive. But when you put the same specimen for growth, there will not be any growth. If at the start of the treatment, it can be a rarest of the rare false positive case of the gene expert. Falsely, it can show us positive. So one should be careful. It is rare in case of retreatment cases. It should be kept in mind in case of new treatment cases, new patients. The harsh decontamination process, we use null continuous. There is a specific time period, like for example, 20 minutes or so. By chance, if the lab technician forgets and keeps for 30 minutes or more, there is a chance that the TB bacilli may die. And you may not get any positivity, culture growth. So the expert, even
Yes, sir. Go on.
if there is any question, is there?
No, no,
Yes,
no.
sir.
This is a background noise. Somebody has not muted the mic. You have
Okay,
to
okay,
continue, sir.
So the other possibility is when the bacilli are not aggregated, that means dispersed bacilli, they may get discarded in the supernatant during concentration by the centrifugation. When we concentrate and supernatant fluid, we discard. So there is a possibility that some of the bacilli will get wasted there. Very less chances, but these are all the possibilities one should keep in mind. When the specimen in MGIT, the culture may get contaminated. When there is a bacterial growth, they consume all the nutrients and they will not allow the bacteria to grow. So they overgrow the TB bacilli, hence there will not be any growth.
Yeah,
Next.
sir. I'd like to intervene. This
Yes, sir.
patient had a positive AFB on the lavage fluid, which was taken on bronchoscopy, and the culture after 6 weeks came negative.
Yes, sir.
So these are the causes Dr. Ravichandra is explaining in this case. The other, I would like to add, sir, that if
Yes.
your bronchoscope is not properly cleaned,
Yeah,
and if you are
that's
doing
true.
too many bronchoscopy in succession in a
Yeah.
busy endoscopy suite, the positive bacilli from the earlier patient may get carried forward to somebody who is not infected. And this is
Oh,
not cross contamination that we, as a bronchoscopist, know this can happen. So this is also one of the possibility with respect to bronchoscopic lavage positive AAB. Yes,
yes,
sir.
sir.
Go on.
Yes, sir.
Yeah.
Yes, sir. Next, sir. So smear positive and culture negativity can also happen. If the patient is on treatment, the bacilli may be dead and hence there will be no growth. If at the start of the treatment, it can be rarest of rare false positive case. Even the smear can be falsely positive. Non-tuberculous mycobacterium is a possibility because smear cannot differentiate between the NTM and M tuberculosis. And when we are growing, there are special methods to differentiate. Capillary test is there, or HPLC is there to differentiate between the Mycobacterium tuberculosis as well as non-tuberculous mycobacteria. All the other causes that are quoted for the gene expert and culture no growth is applicable here also in the smear positive case. Next, sir.
All right.
About the
Just like to intervene. We asked another question in this case,
yes, sir.
that what could be the other causes of uh, such scenario where there is a AFB positive and there is a bronchiectasis in the upper lobe. So these are few questions that come to your mind when tuberculosis is. It seems like a tuberculosis, but it is not, and that is why we have asked Dr. Ravichandra to shed some light on non-tuberculous mycobacteria. Yes, sir.
Yeah, non-tuberculous mycobacteria, before going into that, let us know that there is a Mycobacterium tuberculosis complex, which is not just Mycobacterium hominis, it is a complex containing more than one bacilli, like M. bovis, Mycobacterium bovis, Africanum, Microti, Pinnipedi, Kennedy. These are all different bacteria, which are the constituents of Mycobacterium tuberculosis complex. All of them can cause disease in the humans. So other than this, there are non-tuberculous mycobacteria. So all these bacteria are diagnosed by gene experts because they share large part of their DNA with Mycobacterium hominis. Next, sir. Next. So the other NTMs are, there are many NTMs like Mycobacterium avium and intracellular. That is MAC infections, very common. Then the Chilone, the Fortutum complex, the Kansasi, the Genitalium, smegmatis, etc. So these are all the other possibilities. So which can cause disease. More so, they are all the contaminants from the water and earth. If there is a contamination, there is a possibility. So in these cases, there can be culture growth, but gene expert will be negative. This is the reverse. Gene expert, though it is a very sensitive method, it is negative, but there is a culture positivity. And if the DST is done, you will have funny results and it will be more confusing. Patient may be put on MDR treatment or XDR treatment without knowing that it is not at all TB, it is an NTM infection. In NTMs, depending on the species, there are the other treatments. For MAC, I will be elaborating clarithromycin 500 mg twice a day, ethambutol 15 mg per kg body weight, rifabutin 300 mg per day. The alternative regimen, this is the first one is the first choice. The second choice can be azithromycin 500 mg daily, ethambutol 15 mg per kg body weight, and rifabutin 300 to 450 mg per day. This is possible. The other NTMs, of course, there are other drugs which can be used. Fluoroquinolones, standard ATT suffices in case of smegmatis. Sulfamethoxazole, linezolate, doxycycline, imipenem, and other depending on the sensitivity. So susceptibility test has to be, so speciation has to be done and susceptibility test has to be done to know the drugs that has to be given. ATS guidelines are very useful, which can be referred to in these cases.
Okay,
Thank
sir.
you.
Thank you, Dr. Ravichandra, for nice presentation. I see Dr. Mysore Srinath is in the audience.
Yes, sir.
I'll just unmute him. Are you there, sir, Dr.
Yeah,
Srinivas
I'm
Kumar?
there.
Yeah.
Yeah, I'm there.
So you know the case that this patient is BAL positive for AFB and the culture has come negative. My dilemma is whether to continue treating this patient, which I am doing actually, because this patient clinically has shown weight gain after a weight loss. What is your opinion, sir? What we should be doing in such cases where there is a
Yeah, I
clinical
think
evidence? But
I think we should go by clinical picture. Like
okay,
if he's responding symptomatically,
okay,
I think we should go ahead with uh, the treatment,
okay.
anti-tubercular treatment.
And
That's number one.
yeah,
And
yes, sir.
also think of some other bacteria which do colonize the post-tubercular bronchiectatic lesions, which you apparently have shown on the X-ray.
Yes, sir.
You've already alluded to non-tubercular mycobacteria.
Yes, sir.
So that's another possibility. And any bronchiectatic change, patch could be a nidus for various other non-tubercular bacteria like Pseudomonas, Acinetobacter, gram-negative bacteria, mixed infections. All those things can be taken, but those they don't present like in a chronic fashion as in this particular patient. So this particular patient who is a male and has having a chronic cough, chronic thing, and you have a bronchiectatic lesions right upper lobe, probably, and then responding to tubercular treatment, anti-tubercular treatment, I think we should go ahead treating him.
All right, sir. The
A couple of points I need to tell. I mean,
yes,
like,
sir.
it's always pertinent to remember, keep in mind, I mean, the non-tuberculous mycobacteria in such scenarios, in chronic lungers, like where you have a previous bronchiectasis. Bronchiectasis and non-tubercular mycobacteria, they go hand in hand. One eats on the other. Like So that's one thing. And then in underlying COPD, pneumoconiosis, and so many other diseases can predispose to a colonization as well as a causation. Like there can be a causality of the disease due to non-tubercular mycobacteria. So before we ask for a diagnosis, microbiological diagnosis, I think we should tell the laboratory that we are suspecting this particular non-tubercular mycobacteria.
All right.
I think that should be the main point I would like to tell. Otherwise, generally it's missed.
Yeah. Okay. So some of the doctors, which even I feel, what about your opinion on actinomycosis or nocardiosis presentation? Similar to this case.
Yeah, they do present. Particularly in bronchiectasis, nocardiosis is seen. We have seen, a couple of patients. They almost look similar. They do colonize and they do cause disease in a previously bronchiectatic patient.
Yeah, but if the if the microbiologist is not alert, the actinomycosis and the nocardia, they are weakly AFB positive. So
yeah,
how often?
So they may miss out. You should always keep in mind.
Yeah, and how often do you
whenever there is an underlying lung disease?
Okay. How often do you see such errors, microbiological errors?
Quite often, in the whole of my 10-20 years of TB service, I must have seen a few non-tubercular mycobacteria and very few, actinomycosis or nocardiosis.
So in general, 1 to 4, sir, 1 to 4% is the incidence of NTM in case of.
Yeah. So the problem is they have to be identified and they have to be speciated. We have seen, where it hasn't fitted in the clinical picture. They have, because they can be colonized. They are ubiquitous. They are present in water. They are present in everywhere. They are known to grow in very hard solutions like solvents and all. So as somebody said, as a Dr. Dutt said, probably I think we should first rule out contamination, number one.
Yes.
Number two, and then we should follow those ATS guidelines.
Yes,
there should be wherein they say there should be a compatible clinical picture.
Yes.
And then we should be able to what we call see the organism in the specimen as well as in the blood. Probably they are more specific.
Okay. Any questions from the audience to our expert panel, to Dr. Srinivas Kumar or Dr. Ravichandra? They can ask any questions related to this case or tuberculosis in elderly. Any questions anybody wants to ask about tuberculosis in general? That is also welcome. Dr. Pinaki Sengupta is asking some question. Yes, sir. Go ahead. I don't know whether I have muted him. Oh, I'll unmute you, sir. Yes, sir.
As it has been mentioned that there is a high incidences of antitubercular toxicity in the elderly. So suppose your patient develops toxicity to this normal or first line antitubercular drug, then how you should proceed with this people?
Dr.
And particularly in a situation where you are not sure that whether this patient actually has tuberculosis or not.
Of course, sir, once we have started on ATT, there should not be any doubt about continuing the treatment and completing the treatment. We should, unless otherwise we have an alternative diagnosis, there is no question of stopping. We are firm about our diagnosis and we are going to continue and complete the treatment. Now, if there is any adverse effect What type of adverse effect the patient is having, we should be able to differentiate. That is our clinical acumen. By chance, if the patient have a biochemical abnormality like LFT is deranged, and see, for example, within 1 month or so, if there is a bilirubin rise and the enzymes are not rising, so bilirubin may be
Yes.
rise because of the rifampicin, or
Yes.
if there is a derangement in the enzymes are rising up to 3 into upper limit, and the patient
Yes.
is symptomatic. In that case, we should be stopping the drugs and reintroduce the drugs uh, in a methodic way. Like, for example, INH, you are going to start with lesser dose like 50 mg. Next day, you are going to give 300 mg. Then you are going to see third day if there is any side effect, or like that. So in a methodic way, we are going to introduce one after the other drug and see to it that the patient is not having, after resolution of the jaundice or the enzymes, they have come to the normal level now. Then you start
Okay.
off and give the drugs. For example, if the patient is having visual acuity, so one should be very careful, because in case of elderly, they will not be able to differentiate. So the best is the color chart should be there, Ishihara and Snellen chart should be there when the patient is on ethambutol, especially so in case of elderly and pediatrics. So after some time, if you are not observing, the patient is having visual acuity problem, then you cannot reverse it. There will be a very big problem. It will be very difficult to justify our action. So we should be more alert. The patient is put on ethambutol. In the same way, any drug, like for example, MDR drug. So there was a celebrated case of Nandini Venkatesh. The patient was a Kuchipudi dancer, I think from Pune. So she was put on MDR treatment, and she developed a hearing defect. Probably that time the doctor missed, or the patient didn't complain. And after certain stage, probably the patient was advised not to take the injectable, but the deafness continued. The patient became stone deaf. So we don't know at what level it will become irreversible. Of course, it is irreversible even at the earlier stage. But if it continues, and if you have stopped it also, probably it is the accumulating effect of these drugs. We don't know the reason. They may continue, and totally the patient may become deaf. So
There is a question coming, sir, from Dr. Ramanag, because we have only 5 minutes left.
yes, sorry.
Dr. Ramanag, can you ask your question, please? Okay, I think this is a technical issue. She says can't hear. It's you have to open up your volume, madam. You have to open up. Anyway, there is no other question. Yes, sir. Any other questions anybody want to
Yeah.
ask?
Yeah. Well, final comment. Like, I mean,
Yes,
before we go for a bronch,
yeah.
when we don't get an adequate sputum, I think there's another thing which we can do, what is called induced sputum.
All right.
Like, we can nebulize them with a normal saline and then ask them to cough out and then bring out some sputum. That's one thing which I need to add. Another thing is like, keep always like clinically also, when we start anti-tubercular treatment, we inform the patient to be alert to what you call the symptom improvement, whether it's improving in his appetite, his weight gain, and all those things, and to watch out for high colored urine throughout 24 hours. I mean, normally you do get an orange colored urine initially, I mean, with the rifampicin, and then any pain in the right hypochondrial region, pain abdomen. These are a few things. And then simple urine test for bile salt, bile pigments could at least screen whenever we have resource crunch. Probably I think these things go a long way to detect early toxicity of anti-tubercular treatment.
All right. Any more questions? We have only 2 minutes left. Otherwise, I'd like to close the session. Um, I thank you, Dr. Ravichandra, who actually stayed back in India itself for this presentation and did not go back home. Uh, uh, that's quite great dedication towards our learning session. And Dr. Srinivas Kumar, who actually at the last moment we had to tell him that it is getting preponed by 1 hour, but he still did reach in time. I thank you all doctors for taking out time for this nationwide learning session. If there are any further questions that doctor wants to ask, please you can WhatsApp Dr. Mysore Srinivas Kumar or Dr. Ravichandra. Will be happy to answer questions on our WhatsApp forum, which is available 24/7. I think there is last minute some. Okay, is Dr. Ravichandra telling us that yes, the discussion can continue at any time. So thank you everyone, and it was pleasure talking to you and taking you through all these clinical cases from wellness center. And I conclude this session with a vote of thanks. Thank you, everyone. Good night.
Thank you.
Thank you, sir. Thank you very much.